Okay, we're ready to go. Welcome, everybody. Thanks for joining me today for this. This is kind of a different topic for us. It's not a clinical topic. It's a topic that kind of relates to how we see patients. What I want to go through is that there's been a lot of confusion in this area of what constitutes direct access, what isn't direct access in the state of California, and also looking at how it kind of interplays with our different payers and some of the do's and don'ts of direct access. So I just wanted to give some clarity of what constitutes direct access. And let's see, slides aren't advancing. There we go. So right now, 20 states have what we call unrestricted direct access. And that means that in those states, there's no limits to anybody accessing a physical therapist directly without a physician's referral for any limited amount, any limits on the amount of time. So it's just show up. Typically what we think of like in a chiropractic office where people just show up and get treated. There are 3 states that are limited to direct access only for evaluations. And until we passed a law called AB 100 about I don't know, it's about 8 years ago or so now, maybe more, 10 years ago, we had that restriction where we could evaluate a patient, but we couldn't initiate treatment without a physician's referral. When we got direct access, we were able to obtain it in a modified manner. So there was a lot of, obviously, resistance to that. What we were told in some of the testimony that occurred in the state legislature in which I was present at, that we were going to kill people, that physical therapists will miss diagnoses of cancer, and they're going to miss dissecting aortas, and they're going to miss all types of things that can manifest themselves with pain, but we're not able to adequately uncover those or diagnose or even screen for those. So the good news is, out of all of that, that since we've instituted direct access, there have not been any complaints to the California PT board for misuse or if any of those fear-mongering types of accusations that we had originally that we are going to kill or hurt people in California for doing direct access. So those things have not panned out, which actually gives us a good position to move California to the next level of direct access at some time in the future. So the basis for really what we hang our hat on in what is direct access and what isn't direct access is the presence of a diagnosis. If somebody has a diagnosis that has been given to them by somebody who's legally able to diagnose in California, then they're technically not direct access because they have had that condition evaluated and diagnosed. So it's not merely somebody just walking in for the first time to your clinic and consider direct access. If they're walking in and they've had a diagnosis but not a referral, they do not fall under the direct access regulations and laws. But we got to really put some caveats on that, and we'll get into that in a minute as to what that really means if they have a diagnosis. And accumulate your questions too, because you probably have some as we go through this. So here's the actual law in section 2620 of the Business and Professions Code. And the main thing in the beginning of this law here is that second paragraph, if any time the PT has reason to believe that the patient has signs or symptoms of a condition that requires treatment beyond the scope of practice of a physical therapist, or the patient is not progressing towards documented treatment goals as demonstrated by objective, measurable, or functional improvement, the PT shall refer, that's a shall, refer the patient to a person holding a physician and surgeon certificate issued by the Medical Board of California, the Osteopathic Medical Board of California, or a person licensed to practice dentistry, podiatric medicine, or chiropractic. So basically, it's listing for you right there who are the authorized individuals to diagnose in that paragraph. But it also says that if during that direct access period, your patient isn't getting better, you have an obligation to refer that patient out. So just understand that word shall in there is very important. when you are treating somebody under direct access, you have 45 calendar days or 12 visits, whichever comes first, that you can treat that patient. And if during that period of time, again, they don't make progress, you should refer them out. At the end of that period of time, before the 12 visits or 45 calendar days, we are required to obtain a dated signature on the physical therapist plan of care, on the plan of care that you develop, indicating approval of that plan of care. And that approval shall include an in-person patient examination. So, and it's by a physician and surgeon or podiatrist. So there's a tweak here that is different between this slide and the previous slide. The previous slide, it said that we can refer a patient initially out to any healthcare professional that can diagnose, including a chiropractor, if we uncover symptoms that we feel are not consistent with what's under the scope of practice of a PT. But in order to get your plan of care signed, it can only go to these professionals. It cannot go to a chiropractor. And the reason they exclude the chiropractor on the plan of care side is because it doesn't include a chiropractor isn't included to sign off on a plan of care under Medicare. That's really the only reason. I will tell you though, that if any time during those 12 visits or 45 days, your patient goes to anybody who's legally able to diagnose, let's just say they decide to go into the urgent care 3 days into your visits because they're hurting more or something, and they come back with a diagnosis and referral, it's no longer direct access. So again, anytime they obtain a diagnosis, even during the period of the direct access, they are no longer direct access. So those 12 visits, 45 days lift if they have a diagnosis. I'll clarify the diagnosis part in a little bit. In addition to that, when you initiate direct access, you have to provide this statement and have the patient sign it so that they understand that they are under the provisions of direct access and to understand what that means. So that is a must. So that legally ties you and the patient together to the fact that you both recognize the limits of direct access. So some areas that are confused on direct access. If a patient has an existing and verifiable diagnosis, they are not considered direct access. So a patient who visits and receives a diagnosis signed or a signed plan of care before the first 12 visits in 45 days is no longer direct access. And a direct access patient who indicates they have a diagnosis without verification should be considered direct access. So what do I mean by that? So you have a patient that has a diagnosis, but and it may be that they're walking and says, oh, by the way, I've been treated for my shoulder strain before, and I'm coming back. And let's say it wasn't treated by you, it was treated by a different PT group. And they say, yeah, they diagnosed it as a shoulder strain or as a partial rotator cuff tear, but I just had rehab on it. So I know I have a diagnosis. It is your obligation, in order to not classify that patient as direct access, to make sure that you can verify that diagnosis. So how do you verify a diagnosis? You either get the name of that physician and say that you're treating this patient and you either like a referral or you'd like a copy of the medical record, or if the patient brings in an X-ray report with a diagnosis on it, that from a radiologist, that could count. It doesn't have to be in the form of a referral to be a diagnosis. It can just be a diagnosis. But understand it should be something that you feel you can verify. And the reason you have to verify it is because if that patient is harmed during the course of care and there's a claim against you, and you say, oh, the patient had a diagnosis, and they go, from where? Well, the patient told me they had a diagnosis. Was the patient legally able to diagnose himself? No. So who is that diagnosis from? So if you have a diagnosis that you're functioning under from an individual legally able to diagnose, you should document who that person is. And it'd be better to diagnose that you actually got a copy of a written report or spoke with them verbally on the phone or something. And that takes you out of the direct access realm, and you can treat that patient pending payment issues with the insurance company, which we'll talk about. But if they are true direct access, you just go ahead and treat them for the 12 visits or 45 days, and then you have to get them to a physician to sign the plan of care. So a referral or prescription is not required by law to treat a patient in California. There's nothing in our Practice Act that says you have to have a referral or a prescription to treat a patient. It says you have to have a diagnosis. And a referral or prescription that does not have a diagnosis is considered direct access. That's a little bit of a twist. So if you get a script from a doctor that doesn't have a diagnosis on it, and it just says evaluate and treat, and there's no diagnosis, that's really direct access because you don't have a diagnosis. But knowing that if you have that referral from that doctor, that you know now that you have a connection with that doctor, you can send them your plan of care within that 12 visits or 45 days and get that to be signed. And that would verify the diagnosis on there, because you're gonna insert your PT diagnosis in there. So understand that there's little nuances here that are a little bit confusing. One other thing I would have mentioned too is that, and then let me go back to the previous slide here real quick. The bottom line in this paragraph in bold, where it says, the second to bottom line says an in-person patient examination is required. During the pandemic, that is not a requirement. The patient does not have to go into to see the physician in person. They can do it by telehealth. They can do it by phone conversation. That has been waived during the pandemic. And because the pandemic has shown that the waiving of this in-person examination has not caused harm to patients, or have not been any complaints about that, the PT Board of California has put in a piece of legislation to make that in-person patient examination removed from the direct access laws. So a step in the right direction for us, because nobody's been harmed during the pandemic by not having the person themselves go in to see the doctor. And therefore we feel that's a requirement that is not necessary no longer. Maybe I should pause here. Are there any questions right here under these first few slides? Because this is a lot of information that may be new to you right away. If you have any questions, you can just basically unmute yourself and ask. I'm going to go into more detail with questions with examples here. Yes.
I have a question. So just to make clear, so a patient can come in as direct access, or Medicare patient can come in as a direct access, be seen for the first visit for the eval, and then we send out the plan of care to his provider. And once we get the POC signed, we can have that as a prescription, right?
Yeah, anytime, especially with Medicare, a plan of care that's signed by a physician replaces any referral or prescription, or lack of a referral or prescription. And interestingly enough, Medicare has always allowed that in every state of the union. We just haven't done it in California because we can only do the evaluation. But yeah, so that signed plan of care acts as a prescription.
Perfect. Yes, because I do have a clinic that does have Medicare patients that come in without prescriptions sometimes. And at times we have told them that we do need a prescription. But now that I know this, I can tell the clinical director. Thank you.
Yeah, and just remember Medicare, because we have, we do see patients and say that we try to get the plan of care over within 30 days, and we can extend it to 60 days when we document it. But if you have a patient, a Medicare patient, don't think that you have 30 days to get that plan of care signed. If it's a direct access Medicare, you have 12 visits or 45 days to get that thing. So you have to get it signed. So it could shorten the period of time. And it's kind of a dual responsibility with Medicare to get that signed for Medicare payment. Okay.
Hey, Rick, I have a quick question.
Yeah.
The slide number 7, the notice to patient. I don't think we've ever seen that. If so, is that a hard copy notice that we have the patient sign, or is that part of our electronic documentation?
Just another areas of concern and confusion. A patient doesn't become direct access if they're being treated beyond the duration of a referral or prescription. So if you get a referral that says 3 times a week for 4 weeks, and you're at the end of the 4 weeks, and you don't have an ongoing referral, that doesn't turn them into a direct access patient, because on that referral, obviously you're functioning under a diagnosis, which means they're not direct access. Now, it becomes an issue regarding payment, whether you may have that referral. You may not get paid unless there's a referral covering that period of time, but that they don't revert to what we call the direct access patients. And really understand that I could say all this direct access stuff is wonderful and great, but a payer can set their own requirements to have a referral on file. And although over the years we've seen some payers loosen up some of the requirements to have a referral, we're actually seeing some reversal of that with United Healthcare in the last couple of weeks coming out and saying they're reinstituting the need for a referral in a lot of their plans. And that's unfortunate, because United Healthcare often has always been kind of a leader in not recognizing the fact that direct access and earlier intervention and care is more cost effective. But they are reversing it with some of their plans. So that's something that is a concern to us. But there are plans out there that don't require it. However, always note that anytime you have a referral or a prescription, it enhances the establishment of medical necessity. Anytime you have charts requested for payment that a payer says, okay, we want to do an audit and look at your documentation to see if it supports your charging. If you have more ICD-10 codes and you have a referral on hand, that enhances the need for medical necessity or the appropriateness of providing physical therapy. So it's not something that, like you say, with direct access is required, but it helps from a payment standpoint to have that. So just understand that. So a patient who returns for care following discharge without a referral for the same condition should be considered direct access, unless the PT is certain that they are treating the patient for the same previously diagnosed condition and has a mechanism to refer to the documentation of that diagnosis. So it gets kind of confusing sometimes that a patient comes in for direct access, 12 visits, 45 days, you discharge them, let's say, after the first week, and they come back again for the same condition. Oh, it's still hurting me. What do you do with that patient? Can you start a whole new episode of direct access? Well, actually, no. If you evaluate them or reevaluate them and determine that you're treating the same condition and they are beyond that 12 visits or 45 days, you don't start that all over again. It means that that condition did not resolve, and you really are required, back to the original statements that I put up there, to refer that patient out to a physician who can diagnose them. However, if a patient comes back and it's a different condition within a short period of time, then you can start a new direct access period for that condition. So let's give a couple of scenarios here, which may help to make this a little bit clearer. You have a patient is being seen for low back pain under referral from physician, and during the course of care, the patient develops symptoms in the cervical spine. Can you treat the cervical spine? Is this considered a separate condition and therefore initiates timing under direct access? So the answer to this is, if your initial evaluation did include an assessment of the cervical spine and you had your plan of care signed by the physician, then it would not be considered direct access. If the physician's initial referral to you for the low back pain was only for the low back pain, then it could be considered direct access for the neck. But the way to really handle that is really to initiate a new medical record and then start as a direct access for the neck. And you'd have the 12 visits or 45-day limits for that condition. So from a legal standpoint, it would be direct access if you have no diagnosis on the neck, is really kind of the bottom line. But that happens with our patients. We have patients that come in and develop a secondary condition during the course of care, and you can treat that secondary condition, but it becomes complicated. You also have the issues of billing, where you're billing two body parts, and it might be best to set up a separate medical record and to treat that patient on a separate day for that condition. That would help from the billing standpoint. Another scenario, You have a previously diagnosed patient returns to your clinic with a similar complaint and would like to be treated without visiting their physician. Can you treat this patient as direct access? So it would not fall under direct access if through your evaluation you determine that the patient is presenting with a new symptom, with signs and symptoms that are not consistent with the previous diagnosis. You determine the patient is presenting with signs and symptoms that are consistent with the previous diagnosis. So if it's the same diagnosis and you've seen them before and it was diagnosed and they're coming back to you again for the same problem, let's say it's a recurrent knee problem, you have a diagnosis on that knee and they're just coming back to you because it's acting up. You have a diagnosis. If you have a diagnosis, it's not direct access. Now, again, you still have to make sure the insurance will cover it without a new referral, but it would be direct. It would not be direct access. However, if it's they present with a different type of pain, or you suspect it's not the original, the original origin isn't still symptoms isn't the same as what you thought it was. You're questioning what the diagnosis is, or it's something different. It can fall under direct access at that point. So they can come back, but let's just say they come back with knee pain, and you were treating them before for patellofemoral syndrome, and you think that's consistent with patellofemoral syndrome. Well, that's the diagnosis you had before, and you're going to treat them. However, if they're coming back and now you notice there's instability in the knee, and you think they may have damage to an ACL or something, and you think it's something different, then that would become direct access, and you treat them for the 12 visits, up from 12 visits to 45 days, and refer them on. Or you say, you know what, this is too severe of an injury. I need to send you to the doctor right now. So again, it falls under your judgment. So any questions on that scenario? Okay. Scenario 3, a patient presents to you with bilateral hip pain. In a case, they were diagnosed many years ago with rheumatoid arthritis. Can you treat them? And would this be considered direct access? Because they're having bilateral hip pain and they have rheumatoid arthritis. So you have a diagnosis, right? Would you treat them? Yes, you could, because you have a diagnosis. You can treat them either way. You can treat them under direct access, or it's not direct access because they have a diagnosis of rheumatoid arthritis. But should you treat them? Because you're gonna screen that patient, you're gonna evaluate them, and say you're having multiple joint pain. When's the last time you saw your rheumatologist or your primary care doc or your orthopedist? And they tell you, oh God, it's been years. Should you treat them? Is this a patient has a systemic condition with a acute flare-up that probably should have a physician following them? Now you can treat them, but I'd also recommend that you refer them to the physician, back to physician early on in that treatment. In a lot of ways, if you think about it, this is a great opportunity for you to connect with the physician. Say, hey, listen, one of my patients has come in, is a past patient of yours, and I'm treating them for this flare-up, but I think they need a workup from you. Can you follow up if I send them over? You've just created a nice referral relationship with the doctor. The nice thing about that scenario is the patient sought you out first. The patient had enough confidence in you as a physical therapist to say, hey, I've got a musculoskeletal issue. I want to go see my physical therapist. So when that starts happening in our profession, we're on a good roll there, because we know the patients are seeking us out. But understand that that you're still obligated by that very first set of parameters for direct access, which states that if something is occurring beyond the scope of your practice, you must refer them out. You shall refer them out. Any questions on that one? Okay, so we mentioned Medicare already. You don't need a referral to initiate care. You must be able to confirm the patient is under the care of a physician. So if you have a Medicare patient come in and goes, oh, I can treat you direct access, but you know that Medicare is going to require a signature on that plan of care, would you treat that patient if they say they don't really have a primary care doctor or have any doctor? Would you treat them if they're not willing to go to a doctor? I would say no, because you're going to have a signed plan of care within that 12 visits or 45 days. So they have to have a physician who's caring for them. And you have to be pretty confident that you're going to get that signed plan of care from that physician. Maybe by calling the office and saying, hey, I have John Smith in here and I'm treating him. He showed up to the office for an elbow condition. And I'd like to send him over the plan of care over for you to evaluate. Now, the doctor may say, well, we haven't seen Mr. Smith in 2 years. Can you send him over? And you say, sure, send him over. But they may say, you know what, just send us the plan of care. I've had it happen to me where I call the physician's office and they say, oh, thank goodness she just came to you. We'd rather have you take care of her. We'll sign the plan of care. And it's easy. So you have to kind of know the physician and everything. You know, also, I didn't mention in the very first, or one of the first slides, is that you're actually obligated to send your notes to the physician if the patient agrees to it. So anytime you do an evaluation and you establish a plan of care, you ask the patient under direct access, do you have a primary care physician or you have an orthopedist or a neurologist who's caring for you? And they say, yes. Says, would you mind if I sent them this note? It has to be a patient's consent. And that way, now you have a physician on file with you too, which again, elevates the determination of medical necessity because there's technically a physician involved in the care just by sending them that note. So not a bad idea to always try to tie a physician in. So the decision to treat a patient as direct access is yours to make, pending financial considerations. And if a patient has a diagnosis from a practitioner, authorized a diagnosis in California, they're not direct access. And understand that payers establish their own rules. So it's really important to note with the patient that, hey, I'm seeing you under direct access, but you have Anthem Blue Cross, and Anthem Blue Cross usually requires us to have a script or referral in hand. So I'm going to send this over. You have an option either going to the doctor and getting that, or you can contact the doctor, or I'll contact the doctor and say, I have this patient and I'm going to send over a plan of care. Will you sign it? If they don't sign it, there may be, they may not pay the bill and the obligation falls on you as the patient. So I kind of put it in the patient's hands that we're going to do our best to get the doctor to sign off on this. But if we don't get it signed, then the obligation can fall on you. And you can also tell the patient that you can call the doctor and say, hey, I went to my therapist. He's sending over a plan of care to be signed. Can you sign it? And that would get you off the hook. But you always understand the payers have those rules. It's always best to err on the side of caution. That's in a lot of ways, meaning that if you suspect anything, remember to do your red flag screening with these direct access patients. Remember that you uncover something that is more significant in terms of their presentation of pain and other symptoms. All the red flags of weight loss, of pain at night, all the things that might be occurring that are red flags. It's best to err on the side of caution and get that patient to a physician as soon as possible. I think the direct access is a great way for us to elevate our profession and improve access to care. We have opportunities that are emerging, and these are throughout the country now, where physical therapists are becoming the first line of intake into musculoskeletal care for employers that have injured workers that don't necessarily they want to avoid a workers' comp claim. People can access PTs easier. Even have some payers that are reducing the copays if a patient sees a PT first. because they know that would avoid them going to more expensive practitioners and more expensive tests. It's also important that if you have any questions on this regarding any patient situation, you contact the compliance department to see if they're, if what you are doing is you're making the right choice in terms of utilizing direct access. I think the direct access is an opportunity to market ourselves to existing patients. Let existing patients know, hey, you can come here next time. There may be something involving insurance, but you got a problem, you can just schedule to come and see us. And we're here, especially with returning patients that have recurrent conditions and may have chronic conditions that you kind of see over and over again. If you see somebody, and I mentioned the rheumatoid arthritis patient there, but that person had not been to a physician and was developing bilateral joint pain. But somebody with RA that's being managed by a physician that comes back to you for a flare-up is somebody you can treat under direct access, or just treat directly because you have a diagnosis, or they come to you for a different condition, you can treat it under direct access. So it's an opportunity for us to market ourselves to our existing patients and let them know that we're available to treat them in this manner. I think it's a great way to advance the profession, and I think it's going to be pretty logical for us to get to the step of having unrestricted direct access within the next few years. So I think with that was my last slide. Do we have any questions? Questions.
Hey, Rick, I have a question.
Okay, yep.
It may have been embedded in scenario number 2 that you put up there. We'll get a lot of patients that have been coming to therapy. They've seen the doctor post-op, non-op. They've had a prescription. For whatever reason, they're not going back to the doctor. They either don't want to go back to the doctor. The doctor said, you don't have to come back, whatever it may be. But yet the patient still wants to come in and continue therapy, and there's medical necessity. So that would then fall out of, that would not be considered direct access. Going forward, we can see them for however long we want, as long as there's medical necessity.
Yeah, and as long as you have a payment method in place.
And if they want to pay cash, let's say their insurance does run out and they want to keep going and pay cash. Same concept. Once they've had a diagnosis, they're well into the therapy, they can keep coming and switch to cash if they want, and not be bound
and
by
as long as you as a therapist have determined it's medically necessary care, and it doesn't turn. Maintenance care is another discussion, but you're legally you're in the clear there because you're treating a condition that you know of and you can document. Now just understand with direct access, and the patient just comes back to you directly, you still have the exact same documentation requirements as you do with the patient that you're billing insurance or you're seeing under a referral. Direct access doesn't change anything as far as what's required for you to document. So you still have to keep the note and do everything like that. So there's some reason I bring that up, because in past discussions with people, they think, oh, if the patient is cash, I don't have to document it. Well, no, you're still a physical therapist in the state of California. You still have to document it. Yeah.
I have one question too. So you were saying that if we receive a prescription that says evaluate and treat and there's no diagnosis on there, then that would technically be considered direct access because there's no diagnosis, right? What if it says like low back pain, evaluate and treat? That's fine. That's still direct.
So the idea there is that there's something showing that the referral source has looked at that patient and screened them and determined that, okay, they just have low back pain. They don't have a dissecting aorta. That's basically that's basically it. That's what that diagnosis does. Because when a physician puts anything like that on that, it's basically saying they've ruled out other things and put that on there. Any other questions? Okay, you look through. If there's other things that confuse you, feel free to reach out to me directly, and I'll be happy to walk it through with you, because there's always little nuances to these types of things that kind of confuse folks. But and we will make sure you have those notices available to give to your patients that are coming in direct access, because it's a legal requirement.
Yeah,
Anything
thank you for
else?
doing this, Rick. So, like I said, anyone who doesn't have that form, we'll get that over to you. Everyone should have it,
No, they do.
but to let know, and we'll get you the hard copy of that form. We'll try to clear up some of the confusion with Raintree as well, so that way Raintree itself isn't a barrier for us. And then moving forward, our next Lunch and Learn is going to be in May with Matt Kellum, and that one's going to be on defensible documentation. So more so for the clinicians in the group, but another really great Lunch and Learn. That one's actually going to be a full hour, and you are eligible for 1 contact hour for your CEUs as well. So we'll just have to get all of the participants that are there for the full time, and then we'll get you your certificate after that one as well.
Hey,